Hello, everyone. Uh, my name is Tyson Moore. I'm a nurse practitioner at Children's Mercy Hospital in Kansas City, Missouri, and I'm also the American Nephrology Nurses Association pediatric lead. And today we wanted to chat with you and present a webinar on infectious complications in the pediatric kidney transplant population. This webinar will have C&E credits, and you will receive an email how to obtain those credits from ANA after this presentation. So our objectives are quite simple, but very important. We're just going to understand the various infections that occur post-kidney transplant and those challenges that these infections present. Then we're going to appreciate the delicate balance of immunosuppressive medications when considering the risk for rejection versus infection. And lastly, we'll identify common prophylactic medications for those infections and the treatment also for those infections, what medications we use, and some side effects of each medication that may present when you start those medications. So to start off, we have to first think about what is our goal of immunosuppression. So for us, as a nurse practitioner, I have to think about this constantly with the nephrologist, because it's a balance of kind of three things. So we call it the balance of triad, which is immunosuppression, infection, and toxicity that we have to worry about. So those are the three main things that we have to worry about post-kidney transplant. Obviously, the goal is to prevent the body or the host body that received the kidney from attacking attacking the kidney by immune response against the graft. So what that means is we're trying to prevent rejection, the body attacking the new kidney that was transplanted from a donor. That's goal number one. Then we have to prevent complications of immunodeficiency, because those immunosuppressive meds will depress the immune system. So obviously they're going to be immunodeficient. That leads to infections. It can lead to malignancies, something we'll talk about later called post-transplant lymphoproliferative disorder or disease, also known as PTLD, and kind of just various et cetera things when you have immune system deficiency. We also have to then think thirdly about minimizing those toxicities of the immunosuppressive therapy. We don't have perfect drugs right now. Some of our immunosuppressive meds that you'll see us use commonly in pediatric world, which is tacrolimus, can actually injure the kidney if you have too high of a dose, or the body has kind of a more sensitive response to that certain class of medication, which will ultimately on a biopsy, it can show nephrotoxicity, or what we call calcineurin inhibitor toxicity, or CNI toxicity. If you hear any of those words, they're talking about toxicity and injury from that medication. Some of the medications like steroids can cause hypertension along with tacrolimus. So you may have a patient who starts developing hypertension once we start the steroids immediately post-transplant. They're very sensitive. All of a sudden now we have to deal with hypertension. As well as with with prednisone, we get dyslipidemia. We get a lot of weight gain, we get diabetes. So those are just complications. And then ultimately, if we give too much immunosuppression, we can actually suppress their entire bone marrow system. So they may have low white blood cells, they may have anemia, they can even have thrombocytopenia, depending on certain medications and how much we use. So again, this is just a visual. It goes way back to 2007. We've used it in many, many different presentations, but it kind of demonstrates the delicate balance if you were to think of a scale. We have to provide this graft survival by suppressing the immune system, but on the other turn, these are the complications, such as we talked about: infection, nephrotoxicity. We actually can cause cancer or malignancies that can develop from long-term immunosuppression. And then you can actually have an increased risk of cardiovascular morbidity and mortality from immunosuppression as well, that we found out. And I always think of it too, when I'm visualizing treating this patient, I have to think about myself on a tightrope and be very careful not to sway either way, or I'll fall to either infection or rejection. So the risk factors and terminology we'll talk about briefly. Obviously it's a risk factor. It's kind of common sense, but patients who receive immunosuppressive medications are at risk for higher infection. It's kind of a duh, but it's the base of all the things we talk about. And those pediatric patients, might not been exposed to common viruses within the community like adults have. Depending on the age of the patient, we have a lot of patients that have kidney disease since birth and may be in the hospital for very long periods of time where they really didn't have a lot of community exposure to certain viruses. So they have no immunity already built up at the time we transplant them for a defense system for the viruses they may encounter once they leave the hospital. And then common things that people say that you really need to define two different things. So you can have an infection, which is actually just the presence of a viral replication. So you're seeing this on PCRs, and it's indicated by cultures that we obtain or even serological testing, like I said, protein chain reactions or PCR tests we can do for certain viruses to tell, are we seeing signs that the virus is replicating within the patient? Do they actively have a virus going on? And then disease, so some infection, the difference is infection may not cause symptomatology or symptoms from the virus. When they actually have a disease, they're presenting with specific symptoms that are caused by the infectious agent. So you have viremia or even tissue invasion that are present. So like when the viral load or the replication gets so high, then they start spilling over to have disease. And so those are the differences between actually infection, where the patient has the virus, but no symptoms, we're kind of just monitoring, and then disease, they actually are seeing symptoms and complications from the virus being more activated in the body. The first one we'll talk about that we see is herpes simplex. It's well known in the community of medicine and nursing. And so the difference is HSV1 is more commonly associated with the oral lesion. So you're going to see a lot more what we call cold sores. Everybody says a cold sore. That's just herpes simplex virus 1. But it can be extended, we've seen, into the oral cavity and even esophagus if it's very invasive disease. It is spread obviously by oral contact or mucous membrane contact is the most common way. And then we have seen patients where they get such a severe herpes simplex or cold sore, if it gets in the mouth and the throat, it actually can lead to issues with nutritional and fluid intake because there's so much pain they can't eat or drink. And a lot of those patients get admitted for antiviral therapy, and we have to give parenteral nutrition. HSV2 or herpes simplex virus 2, it usually involves the perianal or genital areas, usually called genital herpes. It is spread most commonly by sexual contact. Now, what I will tell you, based on patient practices and with sexual practices, you can see different viruses in different locations. So you can have HSV2 actually in the oral area. And a lot of times you can swab for this, but most commonly it's diagnosed by just a visual exam. You can do viral testing to see the different load amounts again, and then swabbing it to see which type of herpes simplex are you actually dealing with. According to the World Health Organization, and this is of 2023, in 2016, because that's the last available estimates that they had, 3.7 billion people under the age of 50, or about 67% of the global population, have HSV1 infection, whether it's oral or genital, it didn't matter. And that most HSV1 infections are acquired during childhood. So like I said, a lot of our patients come in contact, if we think about little kids, maybe a parent drinks from a cup, then the kid drinks from a cup, or the parent kisses them and didn't know. Kids spread things because they are always putting things in their mouth. So it's one of the most common ones we see, and a lot of patients we test before transplant are positive for HSV1. We just have to think about that post-transplant and what that means. And then genital herpes is caused by obviously the HSV2 infection, as we said, and it affects about 491 million people, or 13% of people aged kind of in our older teenage to adult area, 15 to 49 years worldwide. And that's just still the 2016 data because they didn't have any other estimates. So not as common as HSV1, but still pretty prevalent. So again, we diagnose those based on clinical features. You'll see these kind of pustules or these blister-looking lesions that start, they'll kind of essentially pop, if you will, and then start to crust over. And we obtain the viral swabs of those areas to see if they're positive, and then protein chain reaction or PCRs in the blood to detect is there active disease. And a lot of the viral PCRs help us detect, we know ahead of time, did they have HSV1 or 2, yes or no? And then sometimes we test them post to see, have they come into contact? We think, oh, they have HSV1, do they have HSV2 now? So now they have both. The treatment's very simple. It is a cyclovir or valacyclovir, also known as Valtrex. There's different dosing recommendations on this. I provided this. This is actually some of our standardized protocol that we use, which is very consistent with KDIGO and which is very consistent with all other pharmacy guidelines in treatment of herpes simplex virus 1 and 2 per the literature. So prophylaxis is recommended for recurrent HSV infections, or if you see, we'll also do it for patients that we know are HSV positive. So the recipient is positive at the time of transplant. We'll go ahead and start them sometimes if they've had active disease beforehand. We'll just go ahead and maybe start them on acyclovir for 3 months and kind of watch it, because that's the most critical time. That's the most time that they're under the most amount of immunosuppressive therapy from the induction when we did the transplant to higher trough levels and a lot of higher immunosuppressive goals early on to prevent acute or hyperacute rejection immediately within the first 3 months. HSV1 patients who are negative, recipient is negative, you may see us do it for 2 months. Again, this is very patient specific depending on have they had active disease, do we think they're at risk, what is the risk like, are they very sexually active, at risk for that infection? So it's very patient specific. And then post rejection, you'll see us sometimes more use valsite than either acyclovir or valacyclovir. But you can even start patients who have really recurrent cold sores or genital herpes infections, because when post rejection, we're going to blast them with immunosuppression again to suppress the rejection, puts them at risk then for a flare up of herpes simplex virus. We'll do that for about a month. And again, recurrent, it's just very individualized. But one thing I want you to think about, and we haven't seen this a lot, but it can happen. You have to be careful with long-term acyclovir or IV acyclovir when you're treating these infections, because they can actually cause crystals within the urine that can hurt the kidney. So that's just something from a kind of a nursing pearl. If you see patients on acyclovir or valacyclovir, or they're getting treated for these infections with IV acyclovir, just make sure to be thinking in your head when you're talking with your team, hey, we got to be careful. These medications are at risk for causing crystallization in the urine. Another infection that we deal with is Cytomegalovirus. I see this one a lot, also known as CMV. And this is actually another human herpes virus. It's HHV5. So it's in the herpes virus family. It is one of the most common infections seen in pediatric patients with a kidney transplant, and I will say it's probably one of the most common ones we see here at Children's Mercy. The risk is increased, and this is common sense again, but it's increased due to seronegative pediatric patients, so the recipient, and the adult donor is positive or seropositive. So when we test their blood, the recipient doesn't have any CMV positivity or known disease, no active PCR, but the donor did. That's the highest risk group. It can also be infected with a new strain of CMV from the community. So those patients that I'm talking about didn't have any exposure to it before transplant, maybe were in the hospital for prolonged periods of time since birth, never really had a chance to get, exposed to CMV from the community, so that they can actually have a primary, like, new infection of CMV. Or the other turn, they can, if they're positive, they may have reactivation from a previously acquired CMV if they did have it before. So we kind of get it both ways, and we have to determine, is it primary or was this reactivation of something they already had? That's why we always test recipient and donor ahead of time to know, is the recipient exposed, yes or no, are they positive or negative? And usually we test the donor to know as well, were they positive or negative? And that's just, like I said, diagnosed by quantitative PCR or biopsy. So the reason why we do quantitative is it gives us the actual viral load, versus qualitative, which will just tell you, yep, they had it, but we don't know how active. And you can see it on biopsy as well. And I have a slide I'll show you why it's so hard to diagnose sometimes. The symptoms are very tough at times to diagnose what they have, because it presents like other viral infections. They have fever, malaise, body aches, maybe just not feeling well, like they might have the flu. You may see some leukopenia in the labs or thrombocytopenia. And even cases, I haven't seen it as specific, but they can have elevated liver function test or LFTs. And then the one that really challenges us is when they have gastroenteritis symptoms, like nausea, vomiting, diarrhea, and even sometimes bloody. If you think about trying to diagnose this just based on these symptoms, it's very difficult. So a lot of our patients, when they have these symptoms, will have the PCR test ran to figure out what are we even dealing with, so that we don't miss the disease. Because otherwise you'll just say, oh, it's just a normal viral gastroenteritis, or oh, it's just a normal viral URI. Very common, but when this stuff prolongs or is very severe, you got to be thinking about CMV, or another one we'll talk about, which is EBV, in regards to severe symptoms. CMV, if it's not treated, it has led and can lead to allograft injury, even allograft failure. a lot of colitis. I've seen several cases where they have it in their intestines, specifically their colon. It's very hard to treat. That usually requires EGD or colonoscopy, usually both at the same time. And they'll take a tissue or a biopsy sample and look for CMV activity to see if that's what we're dealing with. Usually they can see and diagnose it based on physical exam, but we just get a confirmation with the actual biopsy looking for what virus it may be. The last one it can cause is malignancy. So the CMV has been known, not necessarily as much in the pediatric population. I don't see it as much, more in the adults, but it can lead to certain, malignancies within other lymphoid tissues. That's where it likes to live. So when we do the biopsy, trying to diagnose this is why you need a renal pathologist, because to me, all this stuff just looks like a painting of scrambled stuff, and it's very hard to diagnose. But this is a picture that we have of actually some pathology of a kidney with active CMV involved. And so this little itty bitty guy here is actually CMV disease on biopsy. So how do we prevent this from happening? And then what happens, how do we treat it if it does occur for CMV? Well, the standard across all boards, and this is usually pretty standardized across many institutions here in the United States for pediatrics kidney transplant, is we're going to give valganciclovir, also known as Valcyte. And you can see here, there's different durations for prophylaxis, depending on, again, the donor positivity or negativity and the recipient positivity or negativity. And these are common protocols and slides I refer to when we're going to transplant somebody and thinking about the plan of care for them, to try to make sure we have them on the right length of prophylaxis and the right dosing of prophylaxis. I've even seen, usually we say 6 months for that highest risk group that we talked about, but I've seen it be up to a year. If we're testing, and sometimes we'll have active PCRs, but no disease, just the infection, we'll just keep on the Valcyte unless it causes complications. Valcyte dosing is pretty standard at 7 milligrams per meter squared times our estimated GFR. This is by the CKID formula. Down below here, I put in what is the formula in case you need it for clinical practices. So that's the formula that you're going to use to calculate that GFR when you're doing the Valcyte dosing. We usually give it every 24 hours or once a day, and your max dosing in our population is going to be 900 milligrams. That's the most we would even give a teenager, or 18, 19, even up to 22-year-old. They're going to max out at 900. The littler kids, you're going to see them more on individualized dosing or even half that dose at 450. We also give an immunoglobulin called CMV immunoglobulin or Cytogam. Again, this is for that high-risk group, the donor positive, recipient negative. And you can see here, we give this its standardized time frames. So given for the donor, again, positivity, recipient negative, and you can see here, whether it be 150, 100, or 50 per kilo, given at certain hours after transplant, and then at certain weeks post-transplant, and then they shouldn't need any more. Monitoring for the CMV, again, we do the CMV PCR quantitative every 2 weeks post-transplant up for 3 months. And then usually they can go monthly and for 3 months after the Valcyte stopped at 6 months. We have patients that we still can, again, it's individualized. We continue on for those that continue to have active PCRs, or maybe they pop positive on a PCR. And for the first time, we'll just continue to monitor that maybe monthly and just keep our eye out to make sure that they don't get disease and maybe they just have infection. This is straight from an article below. I referenced it. It again mimics exactly kind of how we do things. Chelsea Jensen was one of our previous pharmacists to help write this in another institution. But again, I wanted to present this so when you have something as a takeaway and you're like, okay, that's great, we talked about it, but what is the actual dosing recommendations? What's the duration? Who is it recommended for? This is another great example of even some adult dosing there of how we would treat CMV. And the one I did want to comment, sorry, not to forget, is cidofovir. Be very careful with cidofovir. It can cause a lot of issues with kidney impairment. And it's kind of last line for the CMV. When it's just not responding to anything else, it's your last one you're going to go to. So you should not see cidofovir as a primary treatment for CMV disease just because it's very nephrotoxic. You have to be very careful that you give the kidney enough fluid and that you dose it according to their either glomerular filtration rate, or else it can actually cause nephrotoxicity. The kind of cousin to this, also known, the one I want to talk about next was Epstein-Barr virus, also known as EBV. Again, this is a human herpes virus 4. So this is, again, in the herpes virus family that is spread through body fluid again, usually saliva. Some people will even call it the kissing disease. It can cause mononucleosis that you would commonly see in childhood. The causes of infectious mononucleosis, usually what you'll see more symptoms is, again, malaise, headache, low-grade fever. They may come in thinking they have strep throat with tonsillitis or pharyngitis. A lot of times what they'll have is what we call cervical or neck lymphadenopathy. So these kids will have anterior on the front side lymphadenopathy. They'll be pretty big and swollen, and you'll actually see it on the posterior lymph tissue or lymphadenopathy on the back chain of the cervical neck. That's where it's going to pop up. Splenomegaly can also occur in approximately 50% of infected patients that we've seen. So you always got to make sure these kids usually are resting in bed, but you don't want a patient playing a sport with EBV that has splenomegaly, because if you rupture your spleen, it will not end well for the patient and probably require immediate surgery. EBV has also been associated with developing lymphomas. So thinking back to malignancies and carcinomas. EBV is very tricky in that. In patients with kidney transplant, the main concern is the development of the thing that is scariest with EBV for us, which is post-transplant lymphoproliferative disorder or disease, depending on, what terminology you see in the literature. It's been labeled as both. We usually call it post-transplant lymphoproliferative disease. PTLD is the short acronym for that, and I'll have some slides on that as well. That's the scariest one from EBV. Treatment is acyclovir. Again, very similar, but a lot of times we'll actually use Valcyte for EBV. And you say, well, why are you using different ones for different ones, like Valcyte versus acyclovir versus valganciclovir? It kind of depends on how well the actual antiviral medication treats the specific disease. And that's just based on pharmacological data. In complicated cases, very complicated, so they have a lot of involvement. We think that they have a lot of lymphadenopathy. Their PCRs are very high. They have active disease with a lot of these symptoms. We'll actually give IVIG or immunoglobulins to try to push out the virus or boost up their immune system so that they can treat the virus. That's usually the primary purpose of IVIG. Is usually we're trying to increase the immune system up enough, but obviously it won't cause rejection, but it can treat actually the virus itself. And EBV on histopathology, again, if you were to look at this, it just looks like somebody took dot paints and painted everywhere. But this is actually from Batagay et al. In 2004. It's an older article, but it was a nice pathology picture of what we would see on some staining for EBV disease. It is encoded RNA 1 EBR. That's the staining that is done, and it kind of has it. You can see the faint black print down there. It's a specific staining that the renal pathologist will have to do. So when you're sending the tissue, you have to make sure and mention, hey, I'm looking for EBV. Make sure we stain for EBV. It's a very specific staining, and it's kind of a ribonucleic acid stain that they use. It does pop up as red-orange lymphoid cells, and they have strong nuclear positivity. So what do we do about EBV, and how do we, prevent it, at least to start? Again, it's going to start out just very similar to CMV. You're going to have a donor that's positive and a recipient that's negative, the highest risk population, and it kind of goes down from there. The length of prophylaxis will also determine based on positivity and negativity. So if you have a donor that's positive and recipient negative, you're going to see us try to prevent with antivirals, usually Valcyte for 6 to 12 months. If we know that they've maybe had some active EBV, a lot of times these kids will stay on it for a year. We don't like to keep them on it for a year, but it's better to prevent it than it is to get the active disease. And then if you have a patient who's already been exposed, so they were positive, the donor's positive, or the donor was negative, but the patient that got the kidney was positive, those patients you're going to see only maybe 3 to 6 months of antiviral therapy. Here's just another screenshot I grabbed. This is kind of a standard again per the literature, but it's how we actually prevent EBV disease here at Children's Mercy. And again, it's based on 7 milligrams per meter squared, similar to CMV. pretty much you can think of Valcyte being used for valganciclovir for EBV, and CMV prophylaxis is the standard. Below, you have some different dosing per adult guidelines compared to the above one of pediatric, and it's based on creatinine clearance or eGFR as well. And you can see the different staging here for an adolescent, whether it's greater than 60 all the way down to essentially almost borderline CKD5. You have different dosings because you have to renally adjust Valcyte. The complication with Valcyte that we see is that it can cause immunosuppression, or it can cause bone marrow suppression. So a lot of these kids, when we're checking their CBC or their complete blood count, looking at their hemoglobin, looking at their white blood cells, the one that you really need to pay attention to when your patient's on an antiviral medication is the absolute neutrophil count, or the ANC. If your ANC is downtrending, you have to kind of think, well, why is it doing that? Is there a medication that's causing that, like Valcyte? Or is there an infection that's causing some of this downturn? Usually the main cause of neutropenia is a medication is causing it. One of your immunosuppressive medications is causing it. And a lot of times we'll look at Valcyte first because it's the easier one to take them off, not to cause rejection, especially not in the highest risk population. You'll see us kind of back off or decrease or even hold Valcyte. So now let's talk about the scary one that we see from EBV called post-transplant lymphoproliferative disorder, PTLD. So PTLD is an EBV positive B cell proliferation. It's occurring in the setting of immunosuppression, and it's mainly due to decreased T cell immune surveillance. So let's take that and make it into common sense terms. So you have EBV positivity. It's in your B cells, and your B cells live in your lymphoid tissue or your lymph nodes. So you have this EBV positive B cell, it's staying in the lymphoid tissue, and it begins to replicate or proliferate. And nobody's playing checks and balances on it. And the reason that is because the other part of your immune system, your cellular system, your T cells kind of go around, they're your surveillance cells. They're always looking for stuff, and they'll alert certain cells to kill certain cells. So when you have a decreased T cell immune surveillance or immune response kind of surveilling for problems within the body, mainly due to your immunosuppression, it's not then playing checks and balances on these EBV B cells, the EBV positive B cells. The T cells aren't recognizing them as foreign. So they're continuing to replicate without any T cells saying, hey, this is abnormal. And that's all due to your immune suppression. So again, it occurs due to those decreased T cell surveillance because immunosuppression, the T cells do not recognize that the EBV cells are infected, that they have infected these B cells in your lymphoid tissue, and they're kind of just going, well, we're just going to keep producing. The main risk factors for that happening, or the development of PTLD, is the amount of T cell suppression. And that's the main ones we're trying to target to prevent acute cellular rejection. A lot of them, like tacrolimus or CellCept, mycophenolate, mofetil, most two common ones we use. You can see it in azathioprine or Imuran. Even not as much as with sirolimus, that we use that one as well, but not as common to see T cell suppression as much. The main one I worry about with these, the two, are the mycophenolate, mofetil or CellCept that we use, and then the tacrolimus. Those are blocking essentially your T cell responses. And so if you have a lot of immunosuppression and you're blocking those T cells, there's nothing playing checks and balances on those EBV positive B cells within the lymphoid tissue. About 30% of those PTLD are EBV negative, and we're not really sure. It's not really explained in the literature to date why that happens. And so I don't have an explanation for you, but I do want to mention that when people were going to think it was PTLD in the literature, about some of those cases that are EBV negative, it is up to 30%. So it's kind of interesting. And we still investigate this with research to date to try to figure this out. This information comes from Friedberg and Astor. So if you need a good article on PTLD, that's the one I would reference you. It's recent. A very good explanation of PTLD. So PTLD, why do I worry about it? I've seen it. It's the most common malignancy of solid organ transplant recipients. Sign and symptoms, very hard. Again, it's very nonspecific, with just fever, maybe some weight loss, and you're thinking, oh my God, do they have tuberculosis or some other weird disease? Why are they losing weight? I don't understand it. They got fatigue, maybe night sweats. Again, they'll have lymphadenopathy. So this goes back to the physical exam. I've seen it before. you have this patient sitting there on the table, they otherwise look well, and maybe you forget to actually do a lymph node check on the patient. You listen to heart, lungs, you're doing your basic exam, but the one that may get skipped is actually, palpating their lymph nodes to see, do they have any lymphadenopathy? Is there any enlargement of any lymph nodes in any area, axillary, in their pelvic area? But specifically, you're probably going to see more of it in the neck region. Symptoms from other organ involvement, you can see it in the GI tract. So you think your patient has gastroenteritis, and it just prolongs and it gets to severe disease where the patient is admitted and maybe you consult gastroenterology for further help. We've seen it. I haven't seen it here, but I've heard of it being in the lungs. I know of it being in the liver. Again, these are some other areas where your lymph system is, right? Your thymus up in your upper chest. And then you have your lungs have immune system cells in there. So does your liver. And the worst one is when PTLD starts to spread. The scariest case is I've seen it actually get into the brain itself. The patient kept having seizures, almost stroke-like pictures, and vision disturbances, bad headaches. We couldn't figure it out. And come to find out the patient actually had PTLD within their brain because it had migrated up there. So don't poo-poo basic symptoms. Don't be scared, but also just make sure that a patient gets vetted for a thorough exam at every visit. Again, the most common thing you can do, the easiest thing you can do is just watch your Epstein-barr virus or your EBV PCRs. You start seeing one positive, you're trending it, it starts to increase. And you need to have that talk with that nephrologist and say, hey, do we need to decrease their immunosuppression? Their EBV starting to climb. We don't want them to get active disease or end up having PTLD down the line. And they'll appreciate that recommendation because it's the simplest way to treat this. The treatment, though, when you actually have PTLD, it kind of varies by degree and location within the body. You kind of think of it as a cancer. So you got to decrease immunosuppression first, or else you're going to keep having proliferation and active disease because you have no T cells then being able to help you fight the disease. However, when you do that, again, back to our first slides, decrease immunosuppression. Now you're kind of on the side of, well, I don't want them to have rejection on top of PTLD. That would be a nightmare treatment. I've seen, and the literature speaks, that you can give CD20 monoclonal antibody, also known as rituximab. It can deplete B cells. The reason for that is if you deplete the B cells, then you can have no more B cell replication with the EBV positive B cells, and maybe actually deplete some of the ones that are there. The one that gets challenging is when we have to start evolving hemonc. You get chemotherapy and even radiation to try to kill some of those B cells that are positive with EBV, and it can get very challenging trying to balance, rejection versus treatment of PTLD with chemotherapy. Another human herpes virus that I've seen a few patients have is actually human herpes virus 6. I don't think of this one very commonly. It again belongs to the herpes family by the name, but it's closely related to CMV or HHV5, how it presents, how it acts in the body. So if you're sitting here and you're testing CMV and you're testing EBV and something's not making sense, you might mention to the nephrologist or your team, hey, have we thought about human herpes virus 6? It can occur as well and prevent very similar symptoms. The reason for that is about 90%, it can occur in about 90% of children during the first 2 years of life. And obviously they had this little viral infection, you didn't know what it was, it resolved, bada bing, bada boom. It's not one we currently commonly test for pre-transplant as well. And it, like I said, presents normal illness, goes away, it's dormant, good to go. However, then you give immunosuppression, you may actually see higher levels of immunosuppressant HHV6 come back. After the clinical symptoms initially in the first 2 years of life, it's going to remain dormant. So you don't see it until you immunosuppress a patient usually. Reactivation, though, when that happens of the virus can lead to skin rashes. So this thing called Roseola infantum, it can happen. And so I have a picture of that, what it may look like. Again, I'm not the person to ask or consult or discuss rashes with. A lot of rashes look very similar to me, so it's very hard to tell, especially when you're talking about viral exanthems or viral rashes. They all kind of look the same to me. What gets scary, though, is when it causes encephalitis or convulsions. So again, your patient starts having, they didn't have a seizure disorder, they start having seizures. And you're like, what in the world? They're having these CNS involvement. I'm sure your patients are going to get admitted with neuroconsult, but you can't forget about HHV6. It has been known in when you read the literature, the scariest thing that does happen is when it starts getting up into the brain, causing encephalitis. It can cause pneumonitis, but not as commonly. You will see again with all these viruses, some part of or a little part of bone marrow suppression from them. So you think you're suppressing the bone marrow with your immunosuppression, but actually it's the virus doing that. Hepatitis, again, because some of your immune system goes through your liver. And then the worst one would be graft dysfunction, on top of the worst one being the CNS involvement. It is usually tested if no other viruses, again, are deemed to be causative agents. And you can test it by, again, a HHV6 PCR assay to see. You can test the qualitative or quantitative. Again, we're usually doing quantitative because we want to know how high is the load in the body, and give us kind of a benchmark then to go down from. So I have seen patients that have had this. Thank God they did not present with encephalitis. They presented as the normal viral infection. And again, we found it because everything else was negative to date, still kept having these viral symptoms, specifically some GI symptoms. Came to find out it was HHV6. It actually led to the patient having hypertension as well, but we didn't think there was CNS involvement. So can happen. Not common, but can happen. The treatment is going to be just like the other viruses, acyclovir, valacyclovir, or valganciclovir. Valsite, but the two most commonly per the literature that are prescribed for it is acyclovir or valacyclovir. Sorry, and this information comes from the article down there, and it's kind of hidden in the ANNA logo, but that's the article. It's listed on my reference page if you need anything on human herpes virus 6. This is the rash I was talking about. So this is roseola infantum rash. To me, again, can look very similar to any other viral exanthem. This is a classic picture of a patient from Gorman and James here in 2020. The article again is listed. This is the classic picture of roseola infantum rash. Again, looks like every other viral rash to me. You would only know that it's that specific rash by testing for the PCR to detect it. And then leads us to past the human herpes viruses. We're out of there. Now we're talking about polyomaviruses, specifically BK virus. There is another one. Did not talk about it in this lecture, but if you want to read about it, it's called the JC virus. It's in the same polyoma family. We don't commonly see it as high a prevalence as we used to. The most common one we see in the polyomavirus category is called BK virus. It was first detected in 1971, and it was actually termed BK from a Sudanese kidney transplant recipient with ureteric stenosis and found to have the BKV in the urine. So they found it way back in 1971. The BK is just the initials from the patient that was first diagnosed with BKV in the urine with ureteric stenosis. In the general population, it occurs during early childhood with seroprevalence rates up to about 90%, so very common in the population by age 4 of age. And there's the article from the AST 2019 that gives us that data. Problem is, it remains latent like a lot of these viruses, but it's impossible right now to really test for it ahead of time. There are tests for it. I think I have that on another slide maybe. But essentially, some of the assays to test for it ahead of time to date aren't as sensitive and specific as we would like. It remains latent like every other virus, but it remains in the uroepithelium of the renal tubular cells. So it's in the kidney a lot of times. It just stays dormant in the kidney. So in the donor, there's no way really to detect for BK virus since the donor's immune system or the immune system is not suppressed. So the donor has an active immune system keeping the virus at bay. So you don't know it's there because the count load percent of it is very undetectable, if you will. You detect for it in the donor, right? It's not positive. Well, it's because their immune system's keeping it under control. It is able to replicate once the immune suppression begins. So start giving a lot of immunosuppressive right after transplant, BK virus can become active. Biopsy will show tubulointerstitial nephritis. So when we're biopsying for BK, that's what we're looking for. If you see that on a result, you may think of BK. You'll have a highest risk in donor positive and recipient negative like any other virus. But again, how do you know that the donor was positive? Very hard to detect because a lot of times you won't be able to test the amount in the donor. What does BK do? Well, it starts causing viruria. viremia. Worst cases, you'll have ureteral stenosis and even allograft nephropathy. It's been associated with acute rejection and graft failure 24 months after diagnosis. This is one we commonly see because of use of potent immunosuppressive combination therapy of CellSup or mycophenolate and tacrolimus. And they're thought to be probably the most causative reasons to play, the most causative reason you will see BK than pop positive. What I usually see, and it's the harder ones to treat, is when they pop positive right after transplant, because they're going to have this virus kind of going rampant, and your choices to suppress it are very difficult because a lot of times it requires decreased of immunosuppression medications or IVIG, those type of therapies. Most common way I see us test to find out, do you have BK virus? So we'll start seeing the serum creatinine rise. We're like, that doesn't make, that's not good. And a lot of times there's anytime we're post-transplant, we're kind of screening for BK anyways to make sure that their urine is negative. The testing we do is BV PCR virus quantitative. Sorry, it's supposed to be BKV virus PCR quantitative in the urine and blood and copies per milliliter. That's usually the standardized assay that we use. And then there's BKV specific neutralizing antibodies that is what I was talking about to try to detect it early. They're just not, we haven't used them here in the pediatric population, just they're not as specific and sensitive as we would like to really say, do you have BK virus or not? The classic gold standard diagnosis though, to see what is it doing inside the kidney, because you have concerns that it's causing graft issues, you're going to see SV40 staining on renal pathology. So when you're requesting a renal pathology for the biopsy, you need to make sure that you tell the renal pathologist, or the nephrologist, the team needs to tell them, can you please stain it for SV40? And they'll know what you mean. It's a specific stain for polyomaviruses that will then show per this nice renal pathology here. They light up as a brownish color on renal pathology, and you're able to see the degree and the location and how severe it is on the biopsy. And they can even grade and score it for you to tell you how bad your BK nephropathy is. So again, BK virus, like I said earlier, main thing you got to do, decrease immunosuppression. Again, very difficult because you don't want rejection. So in worst cases, you'll have BK virus, decreasing immunosuppression, and now you have BK virus and rejection. Very hard to treat because it's even more of a delicate balance to try to prevent that rejection going down, but prevent the BK replication because of the immunosuppression. We do CellSep or mycophenolate mofetil kinetics, meaning we do an area under the curve and specifically dose mycophenolate in our population versus just giving them some standardized dose, just 300 milligrams. We dose it according to each patient's metabolism or their area under the curve. So you'll see us do kinetics. We'll draw CellSep levels at trough, 1 hour, 2 hours, and 4 hours. And then based on that, we're able to get an area under a curve. It'll give us a number. The range you're trying to target is somewhere between 30 to 60. 30 is your lower end, 60 is obviously your higher end. We try to beat right around 40 to 45 to keep the patients on maintenance around that level. You're seeing BKV. Need to repeat your AUC. Maybe your AUC is 70, maybe it's 65 or the higher end of normal. And you have the ability to decrease your immunosuppression and not cause rejection. So that's a way we can get very specific with our immunosuppressive medications. Worst case scenario, you're giving cidofovir. Like I said, that's last line. We really don't like that. Most common thing you'll see us do is maybe switch their CellSep for leflunomide. It's another type of immunosuppressive medication, but with that, you can have liver issues. We have IVIG to try to crowd out the BK virus, especially if they have it in viremia or in the blood. We'll give IVIG to try to suppress out and push out the virus and give them some immune support to fight the virus. So that's why they're getting the IVIG, is get them kind of that immune support that they need, but not cause rejection. Ciprofloxacin is kind of debated in the literature. And kind of on our experience, there is an article. It's the novel treatment regimen for BK viremia by Zaman from 2014. It suggests that ciprofloxacin and leflunomide can be an effective treatment for BK viremia. I want to caution you guys though, however, the complications that can occur with ciprofloxacin or Cipro, you can get development of microbial resistance with it. obviously, for overuse. That you've had aortic rupture, especially if you haven't had a recent echo on your patient, an echocardiogram to know what does their heart look like, what's their structure, do they have aortic issues already. You can have prolonged QTCs or on the EKG, causing a arrhythmia. And then a lot of times we'll see C. diff with a long-term, or you start using Cipro, you're going to get C. diff infections. And now you're in big trouble because now you're having C. diff on top of everything else that they'll need treatment for. And usually they'll have volume deficits because they're having so much diarrhea that they need IV fluid therapy. So like I said, I personally haven't seen ciprofloxacin work as well as maybe this article suggests when we tried it on our patient population. We kind of shied away from it just due to the complications that we've seen using Cipro long-term to try to keep BK virus at bay. Parvovirus is another one that we see in this population. It is not the one that you're thinking of parvo and dogs that they get the shot for. This is not not the same parvovirus, but same family, if you will. So one that the humans get is called Parvovirus B19. It's also known as fifth disease. If you look at any of the American Academy of Pediatrics and look for fifth disease, or on the CDC fifth disease, they're talking about parvovirus. And the most classic symptom you're going to see on the patient is a slap cheek. Their cheeks are very rosy and very red. It looks like somebody literally slapped them in the cheek. That's usually a parvovirus or fifth disease that you're seeing. It can lead to anemia. Most common thing that we do see is anemia. Usually it's a microcytic anemia. And you would say, well, how do you know that between iron deficiency anemia? Well, usually we're able to check iron levels also in the body, to check ferritin, their iron, their total iron binding capacity, to see that's kind of what we're thinking initially is, hey, do we have their iron status in optimal situation? Are they on some type of oral iron therapy to prevent microcytic anemias? And you may also see a pancytopenia, so the whole bone marrow is suppressed. Thrombotic microangiopathy, similar to what disease we won't go into, but similar to what hemolytic uremic syndrome can cause. This thrombotic microangiopathy, where essentially your red blood cells are being destroyed due to platelet aggregation from little micro thrombi. And in rare cases, graft dysfunction, I would say that I have not seen it in 14 years where it caused graft dysfunction, because we're usually finding it sooner than when it gets to that severe. But when you're looking at your CBC, they got these low platelets, maybe low white blood cells, and this chronic anemia. You've got them on medications to support their anemia, whether it be erythropoietin stimulating agents, ESAs. You have them on IV therapy, and they continue to just have this chronic anemia. Usually, like I said, it's microcytic anemia. Be checking for parvovirus, because the patient may not present classic symptoms where they have slap cheeks, but they have this chronic anemia. May suggest, hey, should we be checking for parvovirus to see if that's the cause of the anemia, when we've essentially elucidated or removed any other type of anemia or reason they would have anemia. You will see here on this is actually some from the bone marrow. It's an aspirate showing some classic features. What they'll have is these big kind of, namely these red blood cell occlusion in the nucleus of a giant. They call it pronormoblast. The arrows are these big kind of cells. That's the parvovirus within affecting kind of your red blood cells. So if they do a bone marrow biopsy, because it's an invasive disease, they may see that on bone marrow is these big pronormoblasts. Sorry. And lastly, I think we'll get into some fungal infections to wrap up here. So fungal infections that we see also is Candida. The ones that get severe are when we get oral Candida or esophageal candiditis. The other ones that can happen are Aspergillus histoplasma. I've seen histoplasma a few times, but most commonly you're going to get a Candida infection, thrush infection in the mouth. Risk factors with anything else is the dose of immunosuppressive medication. Specifically, your calcineurin inhibitors have been, if you have high trough levels, are using a lot of tacrolimus or even cyclosporin, you have to be on the lookout for risk for fungal infections. And then the post-transplant duration and environmental factors, kids putting certain things in their mouth, did they play with something fungal related transmission, but usually it's just commonly from immunosuppression. They're going to occur within your first 6 months. Why? That's when your immunosuppression is the highest. That's when we see this. And it can be fatal. If it gets into the blood, and you have fungemia, it gets very scary. It can be as fatal as 25 up to 80% of the population that get this in the blood. So what do we do to prevent fungal infections? Again, here's just a nice little table you can take away after this lecture. If you ever need a reference to reference back, this is a good one. Again, it's from very common and reliable literature from KDICO and other sources compiled into one kind of standardized protocol. So your length of prophylaxis post-transplant usually is about 3 months. You're going to get antifungal therapy. Most commonly, we try to use nystatin in the mouth. The dose depends on their weight. It's very easy to dose because if they're greater than 30, they get 10. If they're less than 30, they get 5. And they'll get this usually 4 times a day when they're inpatient. And then once they get discharged from post-transplant, they'll go to twice a day as an outpatient for 3, maybe 6 months, but most commonly it's 3 months. The other one we have is fluconazole. The reason we may switch to that one is because statin tastes nasty. It's an orange liquid. If you've ever seen it, used it, doesn't taste the best. So compliance is sometimes hard to get the patients to want to take that. So you can also use fluconazole, 3 milligrams per kilogram with a max of 100. You get that every day. Yeah, and there is a suspension is available as well. It usually is 40 per 1 ml suspension for the little kids that may have a G2 or need the liquid version. Fluconazole, though, you got to be careful. It can increase your tacrolimus levels. It kind of interacts with the metabolism pathway of tacrolimus. So you may see higher levels if your patient's on fluconazole and tacrolimus. If the patient has a fungal infection and is not responding to fluconazole, they might require voriconazole, which can be pretty tough to treat with voriconazole. It's pretty potent. This is after we failed all other options to treat it. It is not first line because it has interactions with many different drugs that we use and has terrible side effects. And then pneumocystis carinii and Giardivosi, I can never say those words, but it causes pneumonia. Think about HIV patients, so PCP or PJP. You have, we don't see this one commonly because our patients are on long-term prophylaxis for this, but it can occur. So if you have a patient that has fever, non-productive cough, they have kind of shortness of breath, dyspnea, tachypnea, and you've done chest x-rays and it's not just some basic viral process, you'll start seeing some pulmonary infiltrates. It's most commonly diagnosed. You can do a CT exam here or MRIs to diagnose it. Chest x-ray is not as specific. You will see a little infiltrate, and usually the radiologist or the team will recommend doing some other imaging to confirm that it really is PCP or PJP. It has to be confirmed usually, though, by obtaining sputum sample or a lung biopsy, so a bronch, in this population, just to get a sample to confirm that is actually what we're dealing with. Prophylaxis is standardized. It's trimethylprim sulfamethoxazole, or TPMS-MZ. Usually we do it for 6 months post-transplant, and we do have to adjust this according to their GFR. So at every visit, we're always checking their GFR to make sure our medications are dosed accordingly to their kidney function. Specifically, those that have been many years out transplant, they are going to just have chronic allograft nephropathy. You have to dose those accordingly to their GFR and not just keep them on the same dose forever. Other ones, if they don't tolerate Bactrim or trimethoprim, is Dapsone. I've also seen us use atovaquone. The most common one, though, we switch to is pentamidine. They can just do a once-a-month inhaled pentamidine or IV pentamidine if they are unable to use the trimethoprim due to side effects. Again, this is just tables to take away. The length of prophylaxis post-transplant, daily for 6 months. It'll start out daily, like I said, daily medication to get every day for 6 months. Then at the 6-month mark, you'll see us flip over to just 3 times a week, whether it's Monday, Tuesday, Wednesday, Monday, Wednesday, Friday. That's the most common kind of scheduling we do for that, 3 times a week. And they'll be that indefinitely because we do not want them to get this. Post-transplant, post-rejection, when they are treated with high-dose steroids or thymoglobulin. So if they have a rejection, post-rejection or treated with thymoglobulin and high-dose steroids for that rejection, you got to be very careful and actually switch them back to daily for 6 weeks on the Bactrim. You can't just keep them on the thrice weekly because it's a higher risk when you give those medications, high-dose steroids or thymoglobulin, if you're treating cellular rejection, to develop one of these infections. So we know that we need to adjust our dosing back every time they have a rejection to go to daily for 6 weeks then they can go back to their thrice weekly. Dosing here, not going to go over it. It's in the table. Take these slides away, use them as a reference. They've worked for us. It's very standardized according to all the literature. So in summary, hope you enjoyed this lecture, but pediatric patients with a kidney transplant are at increased risk for various infections due to immunosuppression. Duh. These infections can lead to increased comorbidities, as we discussed, graft loss, PTLD, or even death and loss in some cases. Managing the immunosuppression in the population is delicate. It is a very delicate balance between rejection and infection, and that's the most common thing we think about when treating these patients is I need to give enough immunosuppression and specific immunosuppression to prevent rejection, but not so much that I'm just giving them because I don't want rejection so bad that I'm causing a lot of infections, because infections, as you've seen, can cause a lot of serious comorbidities as well. Prophylactic medications are essential in decreasing the risk for these infections that the patient may develop. So I can't stress it enough. Make sure these patients are on prophylactic medications per the right duration, the right strength, and the right frequency to make sure that you're not going to cause symptoms or complications, but you're also going to prevent these severe viral infections from becoming not just an infection, but a disease. Here are some references. Again, these will be in the slides. If you need anything, I kind of even put the titles according to specific literature, whether it's CMV, EBV, kind of classified them at BK. But I do want to thank you for your attention. We're at the 1 hour mark almost. I hope you got something from this lecture, and I'm open for any questions or comments that you may have, things you've seen, questions about the slides, or any comments. Ooh, there's something in the chat. Let me see if there's a question. Okay, yes, you will get the slides. Will have a link, I think, for your CNE and also for this as well, so that you have this information. I believe it will be shared in various formats, and usually it's on, if you go to the ANA website, under the pediatric section, a lot of times these same presentations are available to you if you're a member, that you can reference back later. Again, if you need me, just message me through ANNA's Connect, post on the pediatric forum, hey, I need that presentation. I can also email it to you if you need those references, those charts, those tables, to kind of help you make a protocol if you don't have one. Celeste, are you hearing anything else? I don't see. I'll give one more minute just to make sure. Okay, we will make sure you get the slides. I know Celeste will help me with that.
Yes, I'll make sure an email goes out to everyone in attendance to provide the slides. Yep.
All right, Celeste, I think that's it. I don't see any more questions or comments. Again, please, anytime you need anything at all, I can't stress it enough, just message me through ANNA Connect, post on the forum. I need help with whatever it is. I usually, if I don't know the answer, I know somebody that probably does and can get you either literature or contact or something across at least the United States, if not Europe, of whatever you need.
All right. Thank you, Tyson.
Thanks,
you,
everybody.
everyone. Bye.
Bye.